Hi, everyone, and thank you for joining for the fifth session of our neuroblastoma educational program. When we first started this neuroblastoma journey with our son, Shir, we felt completely lost. The internet was filled with overwhelming and sometimes conflicting information. We reached out to other families in the neuroblastoma community for guidance, but we still had to make so many critical decisions, often without fully understanding the medical language or knowing we were supposed to decide. There was so much uncertainty. We began our journey in our home country, Israel, and traveled to the US in search of the best possible treatment for our Shir. When I founded Shir for Life, it was with the dream of helping families like ours. We launched the first International Neuroblastoma Awareness Day on December 5th. And since then, every month, we bring to you the best and most respectful leaders in this field. Our goal is simple: to give you the direct access to the knowledge you need so you can make the best decisions for your child. As always, you can leave your questions here on the Q&A. Those of you who sent me the questions that were already forwarded to Dr. Kushner. Today's webinar is especially personal for me. Dr. Kushner cared for my Shir for almost 7 months and gave everything he had to try and save his life. I know many of you heard about MSK and Dr. Kushner, and I'm truly honored and grateful to welcome him today. Dr. Kushner is a distinguished pediatric oncologist at MSK Memorial Sloan Kettering, specializing in the treatment of neuroblastoma in patients ranging from infants to young adults. At MSK, Dr. Kushner leads many clinical trials, focusing on innovating therapies, all to make this disease a thing of the past. His extensive experience and dedication have significantly contributed to advancing pediatric cancer care. Dr. Kushner, thank you so much for being with us today. We are looking forward to your presentation.
You can hear me, maybe. Thank you so much for your introduction. And I hope you can see my screen. And I'll be glad to start right away. Is that okay? Okay. So again, thank you for inviting me and organizing the meeting and setting up this program. And today's theme, this is the message we have in our treatment program: reducing therapy and minimizing or avoiding toxicity completely for all children with neuroblastoma. There are many aspects of neuroblastoma that are intriguing and counterintuitive, and I'm going to highlight some of those as we go along. It adds to the challenge, but I think also adds to the possibilities of what sometimes looks like really bad disease actually is not really bad disease, and it's curable. Again, the major goals that our team has had is to cure, despite issues like refractoriness or relapse disease. We get many challenging referrals because of those problems of refractory, meaning resistant disease or relapse disease. And again, another part of our goal is to avoid side effects in these young children. So we want to avoid chemotherapy and radiation therapy for many, many children. We avoid cisplatin, which can hurt hearing. We avoid transplant, not only because it doesn't, in our assessment, it doesn't improve outcome, but does carry a lot of side effects. And we're always aiming to reduce the doses. We've been successful actually in reducing the dose of radiation therapy, which also can cause problems. I'm part of a team here that is very large, focusing only on neuroblastoma with nurse practitioners, clinical research nurses who handle the antibody-based therapy, a social worker, and a team of senior attendings, all of whom have been involved in our clinical trials, and we're constantly consulting and talking among ourselves what to do best for our children. Behind the scenes, we have a special laboratory dedicated to neuroblastoma, supervised by Doctors Chung, the Chung couple. We have data managers and biostatisticians and office coordinators to set up scans and schedule things and make things as easy as possible or minimize difficulties for families coming in from far away. And we have a special laboratory on premises here for preparing the vaccine, which is part of our treatment for high-risk neuroblastoma. We have extensive hands-on experience with many patients because we get referrals because of problems, complications from prior transplant, even from antibody or surgery, as I mentioned before, relapse or resistant disease, tumors that are supposedly unresectable, that our surgical colleagues are equipped and often very successful in resecting these tumors. And then there are patients not eligible for studies elsewhere. Patients can come here under any circumstances. There's no treatment or experience that a child can have elsewhere that would mean that we wouldn't be here to be available to come to us, and we could aim to help them. We do get a lot of referrals for immunotherapy related to some of our experience, outpatient treatment, for example, and the vaccine, which unfortunately is still only available here. And we also get referrals for patients who do not want to go through the transplant, which is standard of care elsewhere. Because we have so many children and patients here, we're able to carry out clinical trials and rapidly analyze the results and findings. This is in almost virtually real time. When we see something that we think can help a child or help with establish a better treatment, we're able to implement it very fast. In terms of scheduling scans and surgery and treatments, our institution is super supportive, and we are able to carry out these essential stages of treatment very, very quickly. This is all to the child's advantage. And our institution supports us to do what is best for a patient, even if it's a deviation from the standard clinical trial or protocol. Our priority is the patient, not the protocol. Our inpatient, outpatient services and pharmacists, as well as the radiologists, all extremely experienced, just specializing and focusing on childhood cancer, including neuroblastoma. Our guiding philosophy is to use as little therapy as possible, avoiding toxicity and side effects. Each child that comes here is unique. We brainstorm about each child and plan what might be best, be it chemotherapy, surgery, MIBG therapy, antibody, or careful observation alone without any treatment. So each child is very special and gets top priority attention. We have no bias, I should mention, towards any given type of therapy. If something emerges that even we were not pioneering, but seems to be good for our patient, we'll go with it. Funny thing about, notable things about neuroblastoma is that it is the most common malignancy in the first year of life, and 90% of the children with it are less than 6 years old. That has some advantages, some disadvantages, but it's a gratifying thing to interact with toddlers as the majority. But we are also here for the what was called adolescents or young adults. Again, first principle is first do no harm. So it's not always how do we treat, but do we treat? Is this version of neuroblastoma going to act like a cancer, meaning proliferating, dividing endlessly and spreading throughout the body, or is it something that might burn itself out without any treatment, and so we can spare a child the downside of consequences of therapy? And as I mentioned, as a clinical enigma, it's amazing that you can have children with disease throughout the body, and it requires stage 4S requires no particular therapy. And then on the other side of the coin, you have widespread disease that explodes in a short period of time, taking over the body with large abdominal mass and extensive involvement throughout the skeleton and bone marrow. Fortunately, and one of the things about neuroblastoma, I like to mention that it's in some ways the best childhood cancer to have, because stage for stage, it's the most curable and with the least amount of therapy. So you have the widespread form I was just mentioning, 4S, as standing for special, which can spontaneously resolve despite extensive disease. And very importantly, for local regional, the neuroblastomas that did not spread to distant parts of the body, if they do not have that bad prognostic marker called MICN amplification, These tumors are curable with surgery alone with maybe minimal chemotherapy, which is really remarkable. And then you have the widespread disease, which is curable nowadays because of not only chemotherapy, surgery, radiation therapy, but importantly, immunotherapy, antibody-based therapy. Other childhood cancers, for a local regional tumor, and not completely resected or even resected, involves radiation therapy and chemotherapy. Again, neuroblastoma, very curable with just the surgery alone. Distant disease and other childhood cancers has not, the outlook has not improved much, if at all, in the last several decades, partly because they do not have the effective antibody treatment that we have for our children with neuroblastoma. And this is a quick summary of what our experience has been over the years, and this was done a couple of years ago. But again, the local neuroblastoma, the 4S, if they do not have to make an amplification, it's virtually all curable. With the an amplified high-risk disease, which we defined very carefully, it's at least 60%. We would say it's higher than that now. That was a few years ago. And then remarkably, you have the very young children who do not make an amplification and are cured with just low-dose chemotherapy, and we can often avoid surgery, radiation, and so on. So very remarkable, not always obvious on the surface of that, how things go with neuroblastoma. Talking about the localized neuroblastoma first, without the MECAN amplification, our starting point dating back several decades is no treatment. And this was based on an extensive review of many clinical trials and clinical reports, and we saw no benefit for doing chemotherapy, even when there's residual disease. So we have the so-called N0 approach for these children, and stop, meaning child started therapy elsewhere, and we stopped it because we classified the child as having, again, the low risk disease. So it's a very gratifying situation that we can stop therapy. And then this no therapy plan is even for patients that have larger localized neuroblastoma or stage 3 neuroblastomas, which subsets of which are treated elsewhere as high risk. I'll show some advantage examples. And again, it's remarkable that you can have an incomplete or no resection of the tumor. You don't need to have what's sometimes called heroic surgery. And that avoids injury to nerves that might be affecting the arms or legs and facial nerves, urinating and bowel movements. And sometimes there are patients that have some prognostic markers that or other circumstances are considered a negative kind of issue, but we stick with our overall approach of no therapy. Here, it's good to know nowadays during pregnancy, it's routine to get get sonograms to evaluate the fetus, and often there's an incident, not often, but it's a well-recognized phenomenon that there are incidentally detected adrenal masses consistent with neuroblastoma, and we like to emphasize that these do not need to be even biopsied and can just be observed, just to keep that in mind. And they spontaneously stay stable or regress completely. But it's good to avoid biopsy and excessive testing. Here's an example of a localized MECAN non-amplified that under other circumstances was considered to be high risk, was going through some intensive therapy. When they sought a second opinion here, we stopped therapy completely, and it's very gratifying to avoid even transplant on this child. Again, here another very large tumor crossing what we sometimes used to call the midline, going to the other side, thought to be unresectable, but our surgeons were able to take it out, and the child was spared intensive therapy. Now these neuroblastoma, these masses that I say sometimes managed with just surgery alone are not necessarily trivial size. Here's a 9-month-old, and this cross-section of the abdomen shows how this tumor was occupying most of the abdomen of this child before the symptoms became visible. And our surgeons were able to take this tumor out and no further therapy. The child did develop another problem, which is where there's some reaction of the body against the neuroblastoma that cross-reacts with parts of the brain that can cause some neurological problems. And it's kind of, again, fascinating, although unfortunate, when those symptoms develop even a month after the surgery. But this is the kind of large tumors that we're so pleased that our surgeons are able to take these out without problems for the child afterwards. Now, talking about the infant stage 4, these are the stage 4 metastatic widespread or stage M neuroblastomas, again, without MICA amplification. But it's a fascinating entity in that the child can have massive amounts of disease and yet totally curable with very low dose chemotherapy and no need for radiation therapy, no need for antibody, and sometimes can even avoid surgery. There are reports from Europe. There's a European treatment program. There's a COG treatment program. Again, super successful. But we actually made some modest some changes that we think avoid reduced potential toxicity, such as not using doxorubicin, which could hurt the heart, and instead using cyclophosphamide, which was a combination that was proven to be very, very successful, very effective for neuroblastoma, but it's after these initial clinical trials were established, so they were not used in those very successful programs. Now, here's a very dramatic kind of illustration of the impact of the MICA amplification. So this child, these two 11-month-olds came in roughly about the same time. This child with what we call intermediate risk had visible masses growing out of the bones of the head. You could see them when we examine the child. And these children sometimes are brought to emergency room because of the bumps and so on. And the initial impression often is child abuse. Now this child and this child also had proved to have neuroblastoma, but not as extensive. These are an MIBG scans, and you can see in this one with the intermediate risk throughout the bones. And here, yes, a large mass, but very little in the bones. But a blood test, LDH, a simple blood test, was super high in this one, telling us it was going to be MICA amplified. And this child's LDH was not extremely high, and those correlate with the MICA. So often you need to wait several weeks to know what the MICA is and put off optimal therapy for the child, but we get with the LDH available right away, we're able to determine the drastically different treatments for the high risk versus the intermediate risk. An example of an infant responding to the intermediate risk chemotherapy, here at diagnosis, virtually the whole body was filled with neuroblastoma. It completely resolved with the low dose chemotherapy. And very nice. But here's another situation where, despite massive amount of disease throughout the bone marrow, liver, lungs, all had neuroblastoma, massive amount in the head, there was no change on the MIBG scan with chemotherapy. But the bone marrow did not show active neuroblastoma after with this chemotherapy, with the chemotherapy, and a PET scan was negative. PET scan is a special kind of imaging study that we have a lot of experience with. It helps us many times to determine whether there's active disease, active cancer, or scar tissue, or not cancerous residual disease. And based on a negative PET scan, we stopped therapy on this child. There are many children that come to us. They've been getting extra chemotherapy because the MIBG hasn't made a change in the MIBG scan. We evaluate the child, carry out a PET scan, see it's negative, and stop therapy and spare the child unnecessary amounts of chemotherapy. Here's another example of advanced disease, a very large abdominal mass, and up in the left bottom of the upper chest and lower neck, another big metastasis spread. So we call these stage 4, and meaning stage 4 based on distant lymph node involvement. And some of the blood tests, looked in favorable situation, and our surgeon took out the main mass here, and then we opted to just observe, and this mass gradually, spontaneously regressed. So again, another child who we spared the very difficult kinds of treatments that's used for high-risk neuroblastoma. Now we're getting to the high-risk neuroblastoma, which unfortunately involves about 50% of the neuroblastoma patient population. And there's some very good, widely accepted definitions of what's high risk. And stage 4 meaning metastatic over 18 months of age, or MICAN being positive amplification in almost any kind of stage, localized, as well as what looks like 4S, but if it's MICAN amplified, it's high risk. Then there's some sort of in the gray zone between intermediate risk and high risk. And at our center, we do not necessarily accept MICAN non-amplified advanced local regional neuroblastoma, even at greater than 12 or 18 months of age, but in that age range as high risk. So these young children, we think we're not hurting them by not administering aggressive therapy. And then the standard therapy for a high risk involves, that diagnoses a lot of disease, and so dose intensive strong chemotherapy, surgical resection. If that has gone well, there's minimal residual disease, ideally, and then consolidating that, killing that involved stem cell transplant, radiation therapy, immunotherapy, and differentiation therapy with isotretinoin or cisretinoic acid. One thing about neuroblastoma that's really impressive that it can be, it's overall very chemosensitive. So chemotherapy goes a long way. Here's a child whose MIBG shows the entire skeleton filled with neuroblastoma, and here is after some therapy showing amazing response. And of interest is that the MIBG's material taken up by neuroblastoma, but it also is a lot of it in the bloodstream, and there's a lot of blood carrying MIBG through the liver, for example. But at diagnosis of this child, it was all in the bone. But with the eradication of disease in the bones, the MIBG material was circulating in the bloodstream again. So here you see the liver lighting up. There's no liver here, and that is a dramatic evidence of how much there was a diagnosis and how effective the treatment was. Now, the Goldie-Coleman hypothesis has been a guiding light in our treatment approach to high-risk neuroblastoma with chemotherapy. And the idea is that spontaneous mutations, abnormalities in the genes of tumor cells, can just by chance confer chemoresistance. In other words, the tumor cell can become resistant to chemotherapy. And the number of these drug-resistant groups of neuroblastoma are proportional to how much tumor there is in the child. If there's a large mass and a lot of disease. So the idea is to eradicate these tumor cells as fast as possible to decrease or reduce the risk of emergence of new drug-resistant mutations. So for us, especially at the beginning with the initial cycles of chemotherapy, we're counting the days till the next cycle can start, and it's in standard protocols around the country or world, you set it like 21 days. But for us, even cutting back 2 or 3 days is an advantage. Might help the child to have a better response and not develop chemo-resistant tumor cells. Now, some of the drawbacks of what was our old induction chemotherapy, N8 and COG induction, was hearing loss. And we had a big experience with children getting all sorts of amounts of chemotherapy, cisplatin and carboplatin and so on, transplant. And it was rather discouraging that even 3/4 of children, and severe hearing loss can occur even with only 2 cycles of cisplatin. The other issue that is a drawback is the doxorubicin, a key part of the chemotherapy, doesn't penetrate the central nervous system, meaning the brain and spinal cord, which is protected by what's called a blood-brain barrier from many treatments that go through the rest of the body. And risk of, because of this, we see this problem of relapse in the central nervous system because it's what we call a sanctuary site where the chemotherapy, lots of chemotherapy and antibodies do not penetrate. So we're looking for strategies to minimize that risk and prevent it from happening. Now, the N9 and N10 protocols are our recent and current clinical trials. The N9 was a pilot study with shortened numbers of reduced cycles of chemotherapy, and with the idea of keeping up efficacy, how effective it was in killing the tumor cells, reducing toxic side effects, and how safe it was using some chemotherapy regimens that we developed here and are known to kill tumor cells in different ways. That's called non-cross resistant chemotherapy, and total 4 cycles. And when we showed that there's favorable results, we incorporated a new clinical trial with N9 chemotherapy, and with the idea of and adding in a formal way not only surgery and radiation therapy, but also 2 cycles of treatment that includes the monoclonal antibody naxitamab. So the aim was to introduce antibody in a formal clinical trial as very early from diagnosis, and see if we can get a complete response very early with this kind of approach. Here's an overview of what the timeline of the Sloan Kettering treatment program with the 4 cycles of chemotherapy for about 4 months, by 5 months of starting antibody, and then followed by vaccine. I'll go through these things a little in more detail. Now, just to point out, though, that in this treatment program, some of the features that we like to point out is we think are commendable. Now, I should also, by the way, emphasize before I continue any further that there's no proof that our approach is better than what's the standard around the country, United States, in the Children's Oncology Group, or overseas in the European consortium. They've never been compared one versus the other. Truly remarkable neuroblastoma specialists have developed the treatments that are used by the Children's Oncology Group and by CEOP, the European group. And I just want to really emphasize that our approach has not been compared in a formal way with the outside groups, and I hope we're all doing well for our children. So with the chemotherapy, as I mentioned, only 4 cycles of chemotherapy, no transplant. The idea, better hearing preservation, better fertility, low risk to the major organs like liver, kidneys, heart. It avoids the veno-occlusive disease, one of the side effects of high dose damage, an issue with the liver, and then other problems that can be life-threatening. And we are, as I would like to emphasize, we no longer use cisplatin, although we were the original group that used cisplatin and etoposide that is widely used now, has been widely used for decades now. Radiation therapy, when we developed our treatment program for radiation therapy some time ago, after reviewing a lot of other studies, often laboratory studies, the approach, the timing that we picked, meaning radiation twice a day, was appealing to us because it seemed to have a decreased chance of side effects on the normal tissues. And the standard approach of dosing of 2100 centigrade or 21 gray, these are the terms, we've been trying to reduce, is not particularly high compared to, say, other childhood cancers that often use 4500, for example. But the lower dose, the better, and we did a study with 1800, and now we're using 1500. And also we have proton beam, and I'll be talking about the radiation therapy, but it's nice that our radiation therapy colleagues have a huge experience with neuroblastoma, and we have the facility to apply also all the recognized forms of radiation therapy, which is obviously an advantage for our children. Immunotherapy, one of the nice things about immunotherapy antibody or vaccine is there are no long-term toxicities, unlike, for example, chemotherapy or radiation therapy. And we we've always used our antibodies with just the GM-CSF. We've never actually used interleukin-2, which does have a lot of toxicity. And in other studies has shown not to actually add to improvement and has been dropped, for example, in European trials where it was widely used. Vaccine we use after someone has completed what we would call optimal amounts of antibody-based therapy. And in terms of the vaccine, like with other treatments, we're always thinking of ways that we can possibly make our treatment better, more effective. And we current trial, which I'll mention again later, we're adding, trying to study whether adding GM-CSF, well, concomitant use of the vaccine is helpful, and we add boosters for a longer time to, which we think will improve the chance of long-term control of neuroblastoma, which I'll get into again later. Again, just reducing side effects. We want to avoid hearing aids, so it's basically an unknown finding among our patients because our children are not getting the treatments that very often cause that problem, necessity in children going through these treatments. And hearing is very important for a 2 or 3-year-old as they're developing their speech. So it's really, really nice to avoid that problem. Secondary leukemia chemotherapy can lead to leukemia or what's called myelodysplastic syndrome, an entity that can lead to leukemia, meaning cancer of the blood. Which is curable, but is really an unfortunate problem if it develops, and we're glad to minimize that risk by using less chemotherapy. I mentioned the lower dose of radiation therapy, and the downside of radiation therapy in our young ones is it can impair growth, how tall a child grows. And the young children, meaning 1, 2, 3, for example, getting radiation therapy to the primary tumor often takes in the bones of the backbone that and slows the growth or minimizes the growth of those bones so the child doesn't reach their full height. And then fertility is so important, and without transplant, the chance of being fertile is better. But we do take big efforts nowadays to preserve ovaries and sperm. Now, just quickly over the 4 cycles. The first cycles 1 and 4 involves cyclophosphamide, topotecan, and vincristine, which is unique in the dosing for induction to our institution. Cycle 2 is the ifosfamide carboate toposide, abbreviated ICE. We have several doses which we use ICE. So we have low dose and the higher dosing. This is not the highest, but we find it's very effective and very manageable side effects. And then there's the cyclophosphamide, doxorubicin, vincristine, which is used similar to what's same as that was used with our NA and similar to what's used in children's oncology group. For a long time, we generally like to do it over a 72-hour infusion, and there are reasons for that, not only to avoid, that way it reduces any effect on the heart, but it also might be better for killing tumor cells that are in a large tumor mass as our children routinely have at diagnosis. Again, what's the rationale and aims of this chemotherapy is that beyond, we like to use when we talk about high dose, we don't mean transplant, we mean conventional dose. That means chemotherapy that lowers blood counts, but you don't need to have stem cell rescue. But it's on the higher side of the dosing. And it's been shown in the past that there's very little, if any, shrinkage of major tumor beyond 4 cycles of chemotherapy. Non-cross-resistant regimens, again, these are regimens, the regimens that I mentioned here, all kill tumor cells by different mechanisms. So tumor cells that are resistant to one combination of chemotherapy could be killed by another combination. And reducing long-term toxicity, super important, as I've been mentioning. And we're hoping that we'll be reducing the risk of relapse in the central nervous system, for which we do have treatment, but it's a very unfortunate problem if it arises. But again, as I say, and I'll mention this again later, that we have very optimistic approaches to managing and curing children who go through relapse. So here's some of the rationale for one of the regimens of cyclophosphamide, topotecan, and vincristine, and it replaces overuse of cyclophosphamide, doxorubicin, vincristine. and it replaces the topotecan by doxorubicin by topotecan, which can penetrate the blood-brain barrier and get into the brain and spine. It's non-toxic to major organs. Doxorubicin can hurt the heart. Topotecan does not affect major organs. And in immediate doxorubicin sometimes cause very unfortunate mucositis, meaning mouth sores, throat sores. Topotecan generally does not do that. Compared to what's done in the children's oncology group, also uses the combination of cyclotopo, but without the vincristine. But our dosing is more than 2 times higher than the dose in the children's oncology group, and we also use a higher dose of topotecan. Again, there's a lot of evidence, not only in laboratory studies as well as in patients, that higher dosing really can overcome chemoresistance. In other words, tumor cells that are resistant to one level or amount of chemotherapy can be killed by a higher dose. And also, we think that higher dosing kills more cells right away, and again, to avoid the development, as per the Goldie-Coleman hypothesis, of chemo-resistant clones that just spontaneously develop. The rationale for ICE advantages over the cisplatin etoposide, which we used to use and is still used elsewhere, much less hearing problems. It might be better for preventing relapse in the central nervous system. All these agents cross the blood-brain barrier, and it might be better in terms of anti-neuroblastoma effect. We carried out a big clinical, pilot study to study ICE, and we found very encouraging results, which we reported on. Other issues that are a little different from elsewhere. In the children oncology group we collect stem cells, even though we don't plan to do transplant. We collect them because just in case a child has some trouble with the standard therapy, some of the salvage therapies, for example, MIBG therapy, you need to have stem cells available. So we'll collect stem cells just in case, but hopefully not to have to use them. But we collect after the 3rd or 4th cycle of chemotherapy, versus in COG, it's collected after cycle 2. The first 2 cycles in COG protocol are the same. So we would say that it's a better chance that those that the collection of stem cells in that setting might be at risk for neuroblastoma cell contamination. By doing it after the 3rd or 4th cycle, with the neuroblastoma being exposed to at least two different combinations of chemotherapy, non-cross resistant, it might decrease the chance of this stem cell cancer cells contamination of the stem cells. The other thing is, as I say, we like to get treatments going as fast as possible, and when you do a collection of stem cells, it delays the next cycle. So there's in the COG clinical setting, the different non-cross resistant cycle of chemotherapy with the first 2 cycles, different from the first 2 cycles, is delayed. So these are minor issues. Can't prove that there's an advantage, but we do have a rationale avoiding minimizing risk of occult contamination of the stem cells, and pursuing the therapy that is so crucial for controlling disease and as fast as possible. Surgery we do after the 3rd cycle. Elsewhere, it's usually done after 4 or 5 cycles, or in Europe, and after what's called the Kojak induction. Again, we want to get these, unlike some other tumors, with neuroblastoma, chemotherapy will not eradicate a big mass. So the best way to get rid of the cancer cells within a big mass is to resect it. We've shown in the past that there's very minimal further shrinkage of the big tumors after 3 cycles, and we're happy to take out the tumor after the 3rd cycle, again, to reduce the risk of spontaneous mutations which would confer chemoresistance. Just to kind of summarize a few things up to now in terms of less chemotherapy. We mentioned that no myeloablative chemotherapy, meaning transplant chemotherapy, and it's I'll go over the rationale for avoiding this very big difference between our treatment approach and elsewhere, but it's based largely on our extensive and unique experience, which showed no survival advantage with transplant in the era of anti-GD2 antibodies. And it's really wonderful that our view is that less chemotherapy is a realistic possibility without compromising cure rate survival, because with the advantages of the anti-GD2 antibodies, which in combination with GM-CSF are extremely effective against chemotherapy, against neuroblastoma that has survived strong chemotherapy. And the antibody that we've been piloting, we piloted is based on an earlier version of antibody, which was a mouse version. I don't want to get too advanced involved on that. Developed by Dr. Chung, and he also supervised changing the aspects of the 3F8 into a humanized form, which has advantages, so-called naxitamab and the brand name Danyelza. Key point is that in our clinical trials here, it showed this antibody showed such efficacy and such lack of toxicity that it got approval from the Food and Drug Administration, which is not very common with for childhood medications of any sort, and without, for example, a randomized trial, meaning where half the children get what treatment, half the children do not. We never wanted to carry out any randomized trials with some of our newer therapies because we didn't want to deprive what we thought was very helpful and non-toxic to children with very severe, very bad kinds of disease. And here's a good, picture 10,000 words. Here's a child who had extensive neuroblastoma, got antibody, naxitamab, and GM-CSF, and it's like literally gone, which is just the most rewarding thing to see. Here's another one. This is a child that went through MIBG therapy and still had extensive involvement by MIBG scan as well as the bone marrow, but all cleared after 2 rounds of antibody. But talking about MIBG therapy for a second, we do MIBG therapy here. And there's some differences between how we do it versus elsewhere. We do it in a regular room. We've not spent the there's always a concern because when you do MIBG therapy, the child is radioactive and needs to be protected. The radioactivity exiting from the child is dangerous to the people around them, so child has to be protected. But we've shown that just using even now we use you can see transparent transparent wall or barrier. Here's a transparent version. So the child is in a regular room, parents are in the room, and we didn't have to spend a lot of money to build lead line rooms. We show that it can be done in a regular room. I should also mention that after main side effect of MIBG therapy is damage to the bone marrow where blood is made. So after these treatments, you need to give back stem cells to regrow the blood counts. And the standard elsewhere is automatically infuse the stem cells 2 weeks or so after the treatment. We hold off for about a month and then actually administer a cycle of strong chemotherapy and then give back the stem cells with the idea that, yes, the counts are low, we're going to be giving back stem cells, but let's do everything we can to attack the neuroblastoma, and that's why we'll do a round of chemotherapy before we do the MIBG therapy, then a round of chemotherapy and infuse stem cells. I should say that there was a time when children like this who came to us with widespread disease would go through MIBG therapy. We didn't think that anybody would be enough to handle this. And a child came to us from far away, and the idea was that she really would be a candidate for antibody. Well, let me make it short. We saw this and we recommended MIBG therapy, but they could not pay for it. So they'd come from far away, overseas actually, and instead of turning them away, we said, well, let's just do the antibody, the naxitamab. And we did the naxitamab, and after 2 cycles, there was a complete response. So this changed our thinking so that patients in the past that we thought we should get MIBG therapy and then antibody, there are very few such patients now. Our even with, if you're aware of it, the Curie score, which is a measure of how sensitive the neuroblastomas in the body, Curie score is over 10 and higher in the 20s even, routinely get great responses with the naxitamab and GM-CSF. So there are situations where we do MRVG therapy, but not anywhere near as often as we used to in the past. And here's just a summary of some of the 3 antibodies that we've been involved with or that we use. And it's very worth noting that naxitamab and dinutuximab, which originally was called CH14.18, were both approved. Not only was naxitamab approved by the FDA, but dinutuximab has also been approved. And we're happy to use it in a number of situations. We have, but just some of the comparisons. The dosing that we use with naxitamab is 2.5 times the standard of other antibodies, and that's appealing because in laboratory studies, the amount of antibody you have per tumor cell, the more antibody you have per tumor cell, the better the killing. So higher amounts, which is what we do in our children, might be an advantage compared to the dinutuximab dosing. 3 days, naxitamab is done over 3 days, Monday, Wednesday, Friday. It's usually done outpatient versus the 4 days in a row that requires inpatient. And I should also say the GM-CSF, which we've shown is very effective in improving the results with anti-neuroblastoma results with antibody, is we use a high dose, again, based on laboratory studies that we carried out, showing that the higher dose of GM-CSF is better for making the white blood cells better killers of the neuroblastoma. So we transformed that into our clinic, so our children get higher doses than what's standard. That was developed before there was a standard dose for GM-CSF, but we've stuck with it. And here again, about the GM-CSF, it's great because it has few, if any, side effects. It's easy to use. It doesn't cause a problem that maybe people have heard about the side effect of immunotherapy with interleukin-2 called capillary leak, and GM-CSF does not have that problem. I mentioned the dose response results in laboratory studies showing that higher doses of GM-CSF are better at making the white blood cells, which do the killing with the antibody, better killers. It hypes them up for better killing. And that's why we translated that into patients so that they get 500 of a certain dose compared to the standard 200. And in our clinical experience, there were times when we were using the mouse antibody alone, mouse antibody with different versions of GM-CSF, and then we were able to show in the various clinical trials that it's the effect of the GM-CSF activating the white blood cells that is so advantageous. Now, chemoimmunotherapy, meaning combining antibody and chemotherapy, is a very popular therapy these days for good reason. The clinical trials were showing very good results, and the standard that's done is with dinutuximab at a certain dose for 5 days of the chemotherapy, and antibody during the 4 days, and then the GM-CSF after the completion of that. We designed our trial differently. So there's the same 5 days of chemotherapy, although our dosing of one of the agents, temozolomide, is higher. So 5 days of chemotherapy, and we do 2 doses of the naxitamab during the chemotherapy. And the following week, when the patients get the GM-CSF, we also do antibodies. So the antibody is working with chemotherapy as well as optimally with GM-CSF. Again, the differences between the standard elsewhere and our so-called HITS trial with the abbreviation for humanized VF8, irinotecan, temozolomide, the long name for GM-CSF, HITS. And again, the antibody is infused with chemotherapy and with GM-CSF, and it's all outpatient. The antibody dosage is 2.5 times greater in the cycle than dinutuximab. And the temozolomide dosage also is higher, and without adding particular hematologic toxicity. Now, there's also novel kind of chemoimmunotherapy, combining chemotherapy with antibody. And with dinutuximab or naxitamab, there are situations where we'll use it with cisplatin and cyclophosphamide and topotecan, or low-dose ice. Again, as with the hits, irinotecan and temozolomide, the antibody is administered with chemotherapy and with the GM-CSF. Getting on to the radiation therapy, which I touched on a little bit before, not a key difference, but a notable difference is that elsewhere in the COG, for example, after transplant, the first treatment is done is radiation therapy, and then later on is the antibody. Our view is that it might be more rational to do the antibody as the first treatment after completion of chemotherapy, and because that's working on tumor cells throughout the body, and immediately after do the radiation therapy. So basically, our children are getting antibody and radiation therapy virtually at the same time. So we're not delaying the initiation of the antibody, which is so important for eliminating distant disease. And again, we deliver the radiation in a way that we think reduces side effects of normal tissue by doing 2 doses per day. And the doses, we've been lowering it from the 2100, 21 gray to 18 to 15. We've published already showing that with the 18 over 6 days is totally is just as effective as with 2100 over 7 days. And now our current clinical trials at an even lower dose. And we irradiate the primary site, and there are other sites as well as that we're worried for relapse. MIBG, persistence of MIBG positivity is sort of an obvious thing that you think about radiating. But we also analyze our children, how they were at diagnosis, and we worry about sites. We identify sites that we think might be at risk for problems, and a large mass in the skull, liver involvement, large distant nodes. And we have developed ways to irradiate these sites safely without excessive toxicity, and maybe that decreases the chance of relapse. Now, going over the transplant experience here, I would like to emphasize that transplant was once a major feature in our experience. We published on it, we were excited about it, and as I say right now, we do have no bias to any given type of therapy, but we've come away from transplant. Now, why did we stop doing transplant? It was once considered an exciting treatment for many solid tumors, but we stopped because it showed no benefit and a lot of toxicity. But it continued as a standard treatment for neuroblastoma because of 3 randomized trials. And those trials, which happened a long time ago, we view them as not being particularly relevant now because they did not include key treatments that have been used since at least 2010 for all high-risk neuroblastoma patients, meaning intensive chemotherapy, local radiation therapy, and antibody immunotherapy. There were some additional drawbacks to the randomized trials. One notable thing is that with long-term follow-up, there was no difference in overall survival. Additional rationale for no transplant was that after children getting strong chemotherapy in induction, 5-6 cycles, what is the chance that the chemotherapy that's used in the transplant can kill those tumor cells? We'd say that there's a good possibility that that's not possible. And there was a clinical trial that seemed to show no benefit from, it seems to support that issue. And then, of course, the toxicity, excessive, sometimes the toxicity can lead to death, although most centers these days have very sophisticated supportive teams to get children through the transplant without death, fortunately. But there can be side effects that delay subsequent post-transplant therapy, meaning the radiation therapy and antibody therapy. And we get children in that situation and try to work around the problem. And of course, there's long-term issues such as lung issues and infertility. Just, and we've reporting on our experience without transplant versus chemotherapy. And we stopped doing transplant over 20 years ago because, again, in sequential studies, we didn't see any benefit. But we have a unique experience of patients that came to us for antibody after came to us after transplant elsewhere, who referred to us, and our own group of patients who got antibody after just chemotherapy. This is a unique experience, except for in Barcelona, where one of our where similar results were recently reported. We have a large experience, and that allowed for robust statistical analyses. And as I say, the conclusion was no benefit for transplant. And then when we compare our experience with the children that come to us from post-transplant with the ones that we did not transplant, all enrolled on the same clinical trial, there was no difference in survival. There's no benefit for the children that came to us after transplant. Here's the summary of some of the differences between the COG and Sloan. First-line treatment, again, different number of cycles of induction, the timing of the stem cell collection, transplant or no transplant, timing of antibody, after or before radiation therapy. We get timing of radiation again. We do it after the first cycle of antibody. The different antibodies, both are really, really great, both approved by the FDA, but our first line is naxitamab because it's higher dosing and outpatient, and then in terms of GM-CSF, the difference in the dosing, which it's never been proved to be better, but we have good rationale underlying reasoning to continue that. We have a big experience with survivors. I still remember when we first started curing neuroblastoma and having children that were done with therapy, and we thought they would really need to be monitored for possible late effects of therapy. So, and eventually we started feeding our patients into such a clinic, and it's a really great benefit to have that our specialists there. Getting on to the vaccine, I was saying that this is a standard part of our treatment after a child's completed the what we consider to be the optimal amount of antibody-based therapy. And the overall goal is to achieve prolonged anti-neuroblastoma immunity by having the child make their own antibodies against the neuroblastoma. So the idea behind the vaccine is to have the child make antibodies against GD2 or GD3. These are the markers. These are markers on neuroblastoma. So if there's still neuroblastoma lurking in the body after all the antibody treatment, the vaccine might be effective in terms of having the child make their own antibodies to kill those neuroblastoma cells. And the rationale for the components of the vaccine, all constructed here. The GD2 and GD3 are highly expressed on neuroblastoma, so they make really good targets. The GD2 is obviously the target of the antibodies like dinutuximab and naxitamab, but GD3 is also another very widely present target on neuroblastoma. And then there's some substances that are mixed in with when we construct the vaccine, and these stimulate the immune system and have little or no side effects. The rationale for glucan. Glucan is an agent that is taken with the vaccine, and it's taken orally. There's a group of substances in foods that are called glucans. They come with a reputation of being augmenting the effects of the immune system, and we're always open to ideas of that we think might translate into something good for our patients. And laboratory studies were carried out showing that yes, indeed, glucan can improve the activity, the anti-neuroblastoma activity of antibodies. And so we ended up we carried out clinical trials identifying the optimal dosing and so on. That's what's used in the vaccine. Now, it also has an impact on the microbiome. Microbiome being the bacteria that we all have in our intestines, and it's a recently very hot field because the microbiome, the bacteria in our intestines, can influence our health in many ways, including the immune system. And we have a program here studying the microbiome of our patients in a big based on a big laboratory on the premises. The glucan is easy to take by mouth. There's no major side effects, and we have a special formulation that we provide for our families for all the doses. Just an example. We can only share published results, and here's a very difficult situation where children have already had one or more relapses, prior relapses. Relapse disease does have a bad reputation. We've shown in multiple ways that it is still curable. And in this one of the vaccine trials that we did, we were seeing very good survival and progression-free survival, even with patients that had relapsed several times. And again, some of the findings that we found with the vaccine was that we have the sophisticated, I mentioned, a laboratory where a lot of tests are carried out so we get a good understanding of how our treatments are working. And we are seeing how by getting the responses against having the child make their antibodies against the GD2, GD3 markers is very important for improving outcome. And glucan also seems to maybe increase the child's ability to make antibodies against the neuroblastoma. Some of the findings, again, we're always trying to see how we can make our treatments better. We had an initial schedule for the glucan, but we've thought another version, another kind of scheduling might be better. Originally, we were doing it week 6, after 6 weeks after the start of the vaccine. The idea was to give the child time to make antibodies and then add the glucan. But then we thought that maybe it's worth starting the glucan right at diagnosis based on some of the other laboratory studies that we were seeing. So, and we found that it was indeed better to start in the first week. Now, the current trial that we have with the vaccine, again, we're always looking for ways to improve our results. And one idea was that maybe GM-CSF used concomitantly with the vaccine would be helpful. But we're not sure. It might hurt, it might help. So that's why it's a randomized trial. So half the children get it, half do not. We also added boosters at the end of the second year and the end of the third year. The initial trial was only through 1 year. The idea was that maybe with these later boosters to keep the antibody level, the titers of the antibodies that the child's making at higher levels. So if there's still neuroblastoma that's lurking even a year or 2 or 3 later, these additional boosters might work against that. And obviously, to be sure that our treatment the vaccine is good, we'd have to be compared to another treatment, meaning a prospective randomized trial, which is we were hoping to somehow get set up, but that's not been possible yet. It's interesting to note that some vaccines with similar components, but without concomitant use of glucan, did not elicit the strong antibody responses in the patients. And the idea of inducing the child to make their own antibodies against the neuroblastoma, meaning active, it's called active immunity, rather than passive, where the child just receives the antibodies, there's some potential advantages, and I'll just leave it at that. Just quickly to note that, again, we are really out there to cure, and even in the unfortunate situation where the disease is refractory to initial chemotherapy or there's a relapse, we've been approaching these situations with curative intent. So we always monitor our children very closely and try to catch relapse very early, which we've shown is advantageous for cure. Here was an example of a neuroblastoma that when it relapsed was not MIBG, taking up MIBG, but we have in our sophisticated way of doing MIBG scan with so-called SPECT imaging. It's also a CT scan, and the CT scan showed this mass would not have been picked up with a regular MIBG scan without SPECT imaging. Our surgeon took this out and this child was cured. The brain, I'm talking about relapse in the brain, central nervous system. You can have relapses there that do not show up on MIBG scan and do not cause symptoms. So we're very, we have a routine of carrying out MRIs of the head on a regular basis to try to nip it in the bud if there is a relapse in the brain. And we have treatments for relapse in the brain. Again, the challenge of the blood-brain barrier prevents treatments getting in there. So in order to get the treatments into the tumor, to reach the tumor cells, we insert what's called an Ohlmeyer reservoir. It's a tubing from the top of the skull and tubing into the middle of the brain where fluid is produced and encircles the brain and spine and can carry. We inject treatments into this area and it's carried around the brain and spine, which to reach the neuroblastoma cells that have escaped this systemic therapies. And omburtamab is another antibody that that Dr. Chung develops called 8H9, and Dr. Kramer was the PI of the initial clinical trials. And this is an antibody that we think is a good basis for treating some central nervous system relapses. And we're hoping that we have a new clinical trial that is in preparation, should be opening in the near future. I'll just summarize very quickly that as children come to us in all different situations through the years, we've developed chemotherapy based on clinical experience, clinical reports elsewhere, and the child's specific situation. And we developed these regimens that are proved to be helpful for different circumstances for each child. Again, each child, we brainstorm about each child and come up with what we think makes the most sense for that child to do well. And again, for relapse, we do use chemoimmunotherapy, and the exact agents that we use the antibodies with is depending on clinical factors, the child's specific situation. Another issue that has really emerged to be very helpful is we have a very sophisticated system of evaluating the genes that are in the building blocks of genes in the tumor cells and identifying mutations, abnormal genes, for which there's often a medication that can be used to kill any tumor cell that has that mutation. And so there are times we do find such mutations and are happy to add the appropriate medication. Another systemic radiation therapy, like MIBG therapy, is a clinical trial that uses Lutathera, another kind of radioactivity, and it's a copper sartate therapy that we use. It's a phase 1 trial, and it's a very nice option for children that have gone through a lot of treatments, including with MIBG therapy. And I'll conclude with the summary that, again, we're really very optimistic that we're curing and able to cure ever more children with this disease and with less toxicity, fewer side effects. And I'll stop there. I should mention that there are some disclosures. I have no disclosures to make, but some of my colleagues do. And I think at this point, maybe open for questions.
Yes, Dr. Kushner, you have questions on the Q&A at the bottom. Already a few questions there.
I don't see them. Where?
You want me to read it to you? You can end your presentation.
No. Okay, so stop.
Yes.
Okay.
And then next to the share button, you can see the Q&A. Right?
Oh, chat, okay.
Q&A.
Oh, there it is, okay. Oh, so should, by mouth, should I answer orally?
Yes,
Answer live, okay. We,
can you just read the
wait,
question
yeah,
so
yeah,
everybody knows?
okay, so, the question is when we're gonna be, reporting results on the first CR patients. And the, we've presented, we expect to do final reports on the initial vaccine trial. So it's something that's coming along. We're very, very enthusiastic about doing that. The second question, the updates on the gut, okay. The updates on the gut microbiome and response to immunotherapy and vaccine. We, our colleague who's supervising that a study will be making a presentation in May, in next month. So I don't have the exact date and timing, but it's in next month that will be presented. Make an amplification impact on survival. Has anything changed in the view of the? Okay, so the next question is, make an amplification impact on survival in already high-risk disease. Has anything changed in the view of the last years, where the prognosis is still considered significantly worse and with greater possibility of relapse? I would say that the at diagnosis, MICAN amplification, not MICAN amplification for the metastatic stage M, stage 4, is really not prognostic. It actually, both groups with or without MICAN amplification have similar cure rates. We did a big review a few years ago, and we found that with the MICAN amplification, if you have an early relapse, that's a bad issue. But people shouldn't be discouraged if the child has MICAN amplification with the standard high-risk stage M neuroblastoma. Now, in terms of the local regional neuroblastomas, like stage 3 in the old terms, or L2 MICAN amplified, we reported our results, and the cure rate is extremely high. So it's really, that's very gratifying if that it's considered high risk, but we would say it's not the it's maybe overcalling it to say that grouping MICAN amplified localized neuroblastomas with MICAN amplified or standard metastatic high risk neuroblastomas. It seems like the MICAN amplified local regional, in our experience, has a very, very high cure rate. The question here is, the Danieleza is only conditionally, the Naxitamab is only conditionally approved by the FDA. Is it not? It's conditionally approved, meaning that it's shown to be because of efficacy against refractory disease and lack of toxicity. They do want additional data experience. We recently published, I'm not sure if it's just in press or not, but exactly what they requested is coming out in Nature Communications, very high level journal, completely supporting the approval. The key thing is it's nice that naxitamab is available worldwide, and lots of groups have been using it, and that's a very nice thing that it's become available, not just as the mouse antibody was only available here at Sloan. When looking at prognostic markers, MICAN is said to be the worst one to have. What is your percentage of survival for children who have both MICAN amplification and ALK amplification? Do you use lorlatinib? Is ALK considered a serious prognostic marker in MSK? So again, as I was saying about the MICAN, it's the MICAN amplification, the cure rates with the stage M or stage 4 MICAN amplified versus not MICAN amplified high risk is similar cure rates. The local regionals with the MICAN amplification have super high cure rates. MICAN ALK is a marker. When it's mutated, it's that gene, I should say the ALK gene is on the same chromosome. The big is right near the MICN gene on a chromosome, one of the building blocks of our cells. And so it's not uncommon for MICAN amplification and ALK amplification to be present together. It's not exactly established whether or not using an inhibitor, ALK inhibitor such as lorlatinib, is beneficial for just ALK amplification. We routinely like to use lorlatinib as that ALK inhibitor when we see a mutation of ALK. So we do have a very large experience with lorlatinib, and we've actually reported on its use in some subsets of children or young adults with neuroblastoma. Is ALK mutation considered a serious prognostic marker in MSK? We don't take that as a prognostic marker, and our treatment program for high-risk neuroblastoma is not influenced by whether or not there's an ALK mutation or not. The brain MRI follow-up, for how long is the patient monitored with MRIs of the brain after front line? Is there any rationale behind the chosen duration? A brain MRI follow-up, for how long is the patient monitored with MRIs in the brain after frontline? Is there a rationale behind the chosen duration? Okay, so certainly through the first 2 years, and in fact, even to get onto our vaccine trial, you need to have a brain MRI. There are risk factors for relapse in the CNS, in the brain or spine. One is MICAN amplification, and one is a spinal tap or a lumbar puncture at diagnosis, which often is done when a children is diagnosed with a cancer, and that that can seed the neuroblastoma at diagnosis is almost never in the brain or spine, at least not detectable. But it's circulating in the bloodstream, and if a child has a lumbar puncture or spinal tap at diagnosis, when you do that procedure, some blood gets into the area, into the CNS, into the central nervous system, and there are neuroblastomas in the blood. So that's a situation that is very worrisome for late relapse in the CNS. And children with the risk factors for CNS relapse, we do MRIs of the brain at least about every 3 months, along with the usual workups. And it's usually through at least 2 years from diagnosis. An MRI of the brain is required before going on the clinical trial. Now, how long is the duration? Again, we brainstorm about each child about what we think is the optimal time to continue doing MRIs of the brain or to stop. So if someone has risk factors or had refractory disease or disease that might make us a little worried, and some children are had MRIs because they had extensive disease in the bones, for example. So it's an individualized assessment when we're going to stop doing that, when we stop doing that trial. which again reflects our approach for many children being not just following a routine, but discussing whether we're following our what we think is best for the child.
Dr. Kushner, since there are so many open questions, I think we should take maybe, and we want to be respectful for your
Okay.
time, for everyone's time. So maybe we'll take another 1 or 2 questions, and if it's
Okay.
okay by you, I will forward you the rest of the
Okay.
questions.
Okay. I'll be
Okay.
glad to get them, really. I hope I didn't take up too much time. And
No, you were
hopefully,
amazing. Yeah,
okay.
you were too interesting. Look how many questions you got.
Okay. So should we we'll just do the next one? Is that okay? Is it talk? Oh, okay. Is there any talks of extending the vaccine trial beyond 3 years? Right now, we're very pleased with the way we have it set up now with 2 boosters in the 2nd year and 1 booster at the end of the 3rd year. The risk of relapse after that is vanishingly low. So we don't think right now. We originally had given some thought about doing it through 5 years, but when we analyzed our results, and again, it's so great here that we have huge number of patients, huge what we call a database, but we can analyze results very fast and come to conclusions very fast and implement modifications and so on. So we're happy right now with the 3-year time frame. Um, um, there's a question here is, do we have, I hope you hear, do we have a treatment for ATRX tumor as they appear to be more prone to chronic disease? Now that there's no specific treatment for ATRX, I should say that of interest to us, ATRX is a gene mutation that is associated with older neuroblastoma in older patients, usually not MYC amplified, but and ATRX associated with chemo resistance, meaning treatments not as the neuroblastoma is not as sensitive to chemotherapy. A couple things, and I can go on talking about so many subjects about neuroblastoma forever, but I really want to just quickly say that the ATRX mutation issue was first identified based on the large number of tumor specimens that our laboratory supervised and set up by Dr. Chung many years ago accumulated. We have a huge tumor bank here for saving tumor specimens, bone marrow, blood, and and we were able to retrieve Dr. Chung retrieved large numbers of our tumors and carried out a trial with St. Jude Children's Research Hospital and identified the ATRX mutation. I'd also like to add another point of interest. Many years ago, when neuroblastoma was not curable, the patients who were older, the older adolescents, young adults, or children over 6 years of age at diagnosis, were able to live longer than the classic high-risk neuroblastoma of a child who's 2 or 3 years of age, because even though the neuroblastoma didn't respond very much, it just percolated along, went along. It didn't burst out in a very bad way. So that these older patients lived longer, not in remission, but they had we call it chronic neuroblastoma. So in the old days, it was quote unquote better. You had longer overall survival, the older patients. Nowadays, with cure rates super high with the low risk, with the younger children with high-risk neuroblastoma, it's the reverse. The older patient is considered to be a more challenging patient to cure. But again, antibody and other therapies, we still view every patient that comes to us, whether they're a toddler or older child or adolescent, we view them as curable. In fact, we've gone from not in the old days, years ago, aiming to cure one child with high-risk neuroblastoma, to now we've gotten to the point where if we don't cure them, we wonder what went wrong, why it didn't happen. Now, we're certainly not satisfied. We won't be satisfied till we get 100% cure rate with no side effects, but we're making amazing advances. Not only our team, but also throughout the United States and Europe as well.
Okay, I think I'm gonna send
Okay.
you the rest of the questions since we have a lot. And I wanted to really thank you for your time and your patience and your dedication. Thank you for everything you're doing. I really appreciate your everything you're doing. Our next session will be kind of correlated with what you mentioned in some of your slides, will be about the surgery and about the important role it plays with Dr. Laquaglia. That will be here next month on the 5th of every month, the 5th of May. So I hope to see you there. And thank you for joining us again.
Can I
Bye-bye.
just say one word about Dr. Laquaglia?
Of course.
And I can't tell you how many patients I attribute cure to his expertise, and also the other surgeons in our team. How many times, especially in the early years, Dr. Laquaglia would page me to come down to the operating room and show me where the big tumor used to be, and it was all cleared out. And many times, again, these are tumors that were deemed to be unresectable. And getting the tumor out made all the difference in the world, because radiation therapy is effective against the microscopic, the tiny little bits left behind, but not against the big masses. Okay, sorry, stop. Thank you.
That was a very good comment. Thank you for that too. So thank you again, and we'll see you soon. Bye-bye.
Bye.